Okay, so just as we move into this area, there's just there's a couple of main points I'd like to make, each of which is in itself a large topic, which I'm sure will be dealt with elsewhere in the course. But just important as we deal with the topic of mental illness that we remind ourselves who we are as human beings. We are neither, of course, merely spirits, or nor do we say that the spirit is the thing that really matters and we're just kind of entrapped in bodies, nor do we join with modern humanists, materialists, and say that we're essentially bodies from which our mind is a precipitate, that our mind is not a real thing that can be differentiated from the body. It's just a product of neuronal activity, nerve activity. So we do not adhere to that either. We know that we are both body, physical beings, and soul or spirit or mind, mental soul, spirit beings as well. And we know that as human beings then, we're joined together into then psychosomatic wholes, and that our mind, our spirit side, is continuously interacting with our physical, our body side, and in particular then the brain and the mind interact closely with one another. So what happens in the body always impacts the mind. What happens in the mind always impacts the body. There is this continual interaction between them. And this is, of course, especially relevant to mental illness, but it's true for any illness, and it's true for all our activities as human beings. Next slide, thanks. And then, of course, the second topic of relevance is the fact that we are made in God's image, in his likeness. Again, a large subject. But this is who we are as human beings. We are God's representatives serving him here as these spirit body, these psychosomatic beings. And we are made then to be like God, to live in relationship with God, and to live in relationship with one another, because we worship a God who has always been in relationships in the Godhead. Father, Son, and Spirit are relational persons. We do not worship a lonely God, a single person God. We worship a Trinity. And therefore, as people made in his image, we are relational beings. It is not good for man to be alone. And this is, again, so central to understanding mental illness, that being isolated, as people are sadly a lot at the moment, is extremely difficult. We're not made to be alone. When we isolate people in rooms in nursing homes, and we isolate people in their own homes, that's harmful to human beings, because we are relational beings. We are made to be in a series of relationships, of which marriage might be the most intense, but we have relationships of all levels, of different levels of intensity with other people. Those relationships get damaged by mental illness. Damage to those relationships in turn affects our mental and psychosomatic function. So this is who we are. We are image bearers. Next slide, please. And then the second key element of the many things that we could say about the fact that we are God's image bearers is that we were created to be, from Adam onwards, rulers on the earth, kings under God, and therefore to be active, to be working, to be doing things. We are not made to be idle. We are made to be active, yes, in relationships, but through, in all sorts of ways, serving him in the work that he gives us to do. This is, again, integral to who we are. Our creativity, our activity generally, is an expression of our God-likeness. And again, to be indolent, to be restricted from doing things, is harmful to us. And again, mental illnesses impact on our ability to do things, and therefore damage our ability to express our imageness. So just a few quick points that are important to get in our heads as we come to the topic of mental illness. Next slide, please. So mental illnesses then are holistic. If you have some kinds of physical illnesses, like kidney disease, for example, it doesn't impact us in the same way as mental illnesses do. Mental illnesses, by the fact they impact our minds, affect all that we are in a way that doesn't apply to physical illnesses unless they become spread through the whole body and in turn impact the brain and the mind, and therefore through that interaction affect the whole of our beings. But All mental illnesses affect us holistically, totally. And that's part of the reason, in fact, I think probably the main reason why they're so damaging. They're not restricted. When you're mentally ill, you cease to be able to function as an image bearer of God. We'll see this in depression. We'll see it in a future talk in anxiety. We'll see it in dementia. And of course, because of the fact that we are relational beings as image bearers, when the person with mental illness is affected holistically, necessarily the whole of their being, that impacts on their relationships with other people, especially those close to them in their families. Mental illness inevitably affects these relationships in a much deeper, a much more profound way than physical illnesses do. If you've got a family member who's physically ill, it can create some extra work for you to do in caring and taking on other activities, but it doesn't directly impact on your relationship in the way that mental illnesses do, because mental illnesses affect us centrally to who we are, and therefore, because who we are is relational beings, it affects how we relate to those close to us. So understanding who we are as psychosomatic beings and as image-bearing beings helps us to understand why mental illnesses are so devastating for people who have them, and then for those who live with them, love them, and care for them. So next slide, please. So this is a quote from a few years ago. John Horder, I think by this time was retired, had been president of the Royal College of General Practitioners, a GP. So he said he had suffered several serious illnesses, but he said, if I had to choose again, I prefer to avoid the pain of depression. It's a surprisingly physical sensation. That's what people say. It's this impact of mind on body. It's not just a mental thing, as it were, because we're wholes, psychosomatic wholes. Surprising resemblance to coronary pain, that's heart pain, because it too is total. It cannot be relieved quickly, even threatens life. It is oneself and not part of one's machinery, a form of total paralysis of desire, hope, capacity to decide what to do, to think, or to feel, except pain and misery. So it's this pain and misery that engulfs people with depression, that impacts on them in this way. He had severe renal disease, he had renal colic, which is extremely awful pain to have. He had heart attacks, really bad cardiac pain and illness, depression much worse. Next slide, please. Lewis Wolpott was somebody I studied at medical school, an embryologist, professor of embryology. And he had a profound depressive illness as well, and he wrote about this. He said, it was the worst experience of my life, more terrible even than watching my wife die of cancer. I'm ashamed to admit that my depression felt worse than her death, but it is true. I was in a state that bears no resemblance to anything I'd experienced before. It wasn't just feeling low, depressed in the commonly used sense of that word. I was seriously ill. Depression is not the same as normal sadness. Okay, yeah, next slide, thanks. So then, what is mental illness? Before we come to depression, just sort of ask more generally, what kind of thing are we dealing with? So next slide, please. So this might not come as a shock to people in this room, but there is a serious point behind this. And I'll say, why is this not true? Why is this not true? And there is a serious point here. If you go to the next slide, please. So in the British Medical Journal, or BMJ as it's now known, a few years ago, then they had an article, or a series of articles, looking at the new way in which mental illnesses were being categorized for diagnosis, the Diagnostic and Statistical Manual, DSM. It's a kind of Bible for diagnosis and psychiatry. And 4 of these are listed in that manual as supposed mental disorders and mental illnesses. And one is a fictitious one that was invented for this article. I use this in teaching on diagnosis in psychiatry. So, which one of those is not an official mental illness? Now, don't worry, I'm not going to ask you to put up your hands or anything, and I can tell you that psychiatrists don't get this either, okay? The answer is the top one was the invented one, but the rest are listed. Now, none of those are actual illnesses, okay, in my opinion. Next slide, please. So this is why it's a serious issue, isn't it? So you could find other quotes. This is from Khrushchev, when they were locking up people on the grounds of being Christians in Russia. Today we will have brothers, sisters imprisoned in China, North Korea and such places. And I presume there are people in there on the grounds that they're Presbyterians. And they're locked up on the grounds that Presbyterianism has been declared to be some kind of mental illness. That's why I'm saying there's a serious point to understanding what we mean by mental illness. As a psychiatrist, I could lock you up. Well, not quite, but I've got authority from the Secretary of State to fill in a form and declare that you should be treated in hospital where you'll be locked up on a ward. Now, I can't do that on my own for good reasons, but the principle is that our country, like other countries, gives powers to psychiatrists to lock people up who haven't committed any crime, but because they've got mental illness. Now, that's necessary because of the nature of mental illness, but it's also, of course, vulnerable to abuse, as in China today, as in Russia in the past, and so on. Okay, so next slide, please. So what is a mental illness? This is in my book where I go into it in much more detail. So if you go to the next slide, please. So the first point is a behavioural syndrome. That's generally true how we do diagnosis in medicine. You look for a cluster of signs and symptoms, features that run together as a syndrome then. Next slide. But you could define Presbyterianism as a syndrome, or Anglicanism as a syndrome, because you could say that here are the features of the Presbyterian syndrome. They carry out infant baptism. They worship on the Sabbath, or they keep the Sabbath. They sing psalms. They wear suits to church. The women wear skirts and dresses to church. And you know what I mean? You could go on, you could define a syndrome that would identify somebody reasonably accurately as likely to be a Presbyterian and so on. So the syndromal thing is why you can end up with things like pyromania and caffeine intoxication, because you can define any behavior, that political, religious, sexual, whatever, and say there's a syndrome because this is the kind of pattern of behavior. And we all have patterns of behavior, Baptists, Presbyterians, we all have patterns of behavior. That doesn't make us ill, it's just who we are. That's just being human. Okay, next slide, please. So illness is different because illness is a response to some objective cause or causes. This is derived from the National Institutes of Health definition of illness. So the key thing is that either due to an external cause, like a coronavirus, or an internal cause, like a genetic mutation or something, then you get a specific cluster of signs and symptoms, a syndrome that we define as a mental illness. But there needs to be a response to an objective cause. And what you don't have in Diagnostic and Statistical Manual is this. You do not have the necessity for a response to an external or internal cause. It is purely descriptive, and that's why all sorts of things can be defined as mental illnesses in what frankly is a very arbitrary way. And I've joked in talking, you could just invent things. You can have hijacking disorder. You can have road rage. And some of these you actually hear about in the media as if they are supposed to be mental disorders. All they are patterns of behavior. They're not due to a fundamental change in the human being due to an external cause or an internal cause. Next slide, please. Now, it's important that we also, in medicine, generally look for an impairment in functioning, that the impact of whatever's going on that causes the syndrome, that causes the change in us, external or internal, affects our everyday function. And this is certainly true of mental illnesses. We all get down from time to time. We all get anxious from time to time. That doesn't make us ill at that point. If your anxiety or depression is persistent and more severe, and it affects your ability to carry out all your usual everyday work and activities, that's when it kind of crosses by convention into what we'd say is an illness. And again, that's generally true in medicine. Somebody can have pains and problems with their eyesight, pains in their joints. It becomes an illness when it's problematic, when it affects functioning. And finally, next slide, please. So because of the potential for abuse, definitions, including DSM, do have this sort of statement included to make sure that you don't do in this country what's done in other countries, sadly, where they won't adhere to this. So, political, religious, sexual patterns of behaviour are not able to be defined as mental illnesses. Next slide, please. Okay, so with that background, we move then specifically to depression. Next slide, please. So, William Styron is a novelist, award-winning novelist who also had depression. I've not read any of his books apart from this one. So he said, my conviction is that normal sadness is depression, what normal growth is to cancer. It's fundamentally different. Next slide. So for diagnosing depression, we look for 9 core features. This is the syndrome then, these 9 features. And you look for 5 of these to say that this would be a significant, or likely to be a significant depression, that is a depressive illness. So obviously sadness, a change in mood to depressive mood, but these other factors, you're no longer able to enjoy yourself, you lose your energy, you lose your weight because you lose your appetite. There are these fundamental changes in a loss of appetite that is quite profound for people who just simply have no desire to eat at all. And it's very difficult to persuade people to eat. They can't sleep. Again, not just a disturbed night, but night after night of horrific inability to sleep, filled with horrible pessimistic thinking. Your concentration is impaired. Suicidal thinking is common, not universal, but very common. And then there's a psychomotor, so it affects our bodily function as well. So psychomotor means the mind affects our movements, our motor movement function in the body because we're psychosomatic wholes. Next slide, please. Now, depression is a terrible term. I'd far prefer it to be called melancholia, which was the old term that was used till depression came along. So this is Lewis Walpott. Again, severe depression borders on beyond description, not just feeling lower than usual. It's a quite different state, a state that bears only a tangential resemblance to normal emotion. Depression, yes, it's about a profound sadness, but it's much more than that. Just try to think of it as sadness doesn't do it justice. This is what Lewis Walpott's trying to capture. So he says, it's not just sadness and normal emotion that's gone wrong. It deserves some new and special word of its own, a word that would so encapsulate with the pain and the conviction that no remedy will come. We certainly could do better than this word with a mere common connotation of being down. It's not just being a bit down. Next slide, please. So depression, a wimp of a word. So depression, I just like these quotes from Styron. He's a novelist, so he can write well. Depression is a word that has slithered through the language like a slug, leaving little trace of its intrinsic malevolence and preventing by its very insipidity a general awareness of the horrible intensity of the disease when out of control. So it's this thing, it isn't just being down. That's why you don't like the word depression, it just says you're a bit down. Melancholia would appear to be a far more apt and evocative word for the blacker forms, because of course melancholy is from blackness, but it was usurped by a noun, depression, with a bland tonality and a lacking any magisterial presence, used indifferently to describe an economic decline or a rut in the ground, a true wimp of a word for a major illness. Okay, next slide, please. So trying to make the point, depression is not just sadness. It's not just people being a bit down. It's a profound and horrible illness. Now, there are lots of things that are called depression. Okay, there are lots of things. Depression has become a huge umbrella under which all sorts of things that aren't illnesses nestle. So as I said, normal sadness, we all get down. Life is full of trials and difficulties, and we have normal reactions as image bearers to that, and normal emotions congruent, consistent with those experiences that make us feel sad. That's not depression. Spiritual depression is a term that's used. There's an article I wrote earlier this year in the banner of Truth magazine on to understand spiritual depression, what it is, and it's not depressive illness. It's something distinct. Then you get depression when you're sick, because we're psychosomatic wholes. If you've got a bad physical illness, you feel down a bit. That's fine. That's normal because we're human beings who are psychosomatic wholes. That's not what we're talking about here. Then again, grief is part of normal experience in this fallen world where we lose people we love, we suffer with that, we feel profoundly sad, we have grief. Again, it's different. And then there's burnout, which I've spoken on as well and written about. So burnout is a kind of exhaustion syndrome rather than a depression. Depression is a kind of feature in the sense that sadness is part of it, but it's not fundamentally what's going on with burnout. Burnout is psychosomatic exhaustion. Next slide, please. So what I want to focus on is depressions that come into contact with medical services, if you like. So at the top, psychotic depression is the most severe form, moderate depressive illness, and psychosomatic. So what I call psychosomatic, historically, this used to be called neurotic depression, but of course neurosis and the adjective neurotic are kind of words that you're not supposed to use nowadays because they're seen as pejorative. But if you read in books about people who are neurotic, it's this kind of area. And now all these sort of depressive illnesses, they're long-term conditions. Medicine has lots of long-term conditions. Depression and mental illnesses generally are not short-term problems. Next slide, please. Okay, so this is Timothy Rogers, who was a Puritan, 17th century Puritan, who had depression and wrote about this, melancholia as he was called at the time. And he makes the important point here about this thing about you can't just kind of shake yourself out of it. You can't just pull yourself together, as the horrible phrase has it. So it's commonly said by others who do not know what melancholy, that is depression, what melancholy is. Why do you think so much? Divert yourselves. Think of something else. But it's no more possible for people where this disease comes with violence to divert their thoughts than it is possible for a man with a broken arm or a leg to walk and act as he used to do before. They can think of nothing but what they do think, just as a man with a toothache cannot forbear to think of his pain. Though others urge us to rule our thoughts, it gives no relief, but only adds to our misery to be frequently urged to do that which we cannot do. So please don't go and tell people with depression or other mental illnesses, what you need to do is, and that's going to sort things out. It's not possible. Next slide, please. So these are sort of three types of depression, if you like, that I've just said we'll briefly consider. So the outer circle, this is one way of seeing this, okay? So depression is one thing, one illness, one syndrome arising from that, with the psychosomatic, the mildest form, obviously I think the most number of people, and these are supposed to be kind of annual numbers or percentages in the population. So very high. Now I think this is too high, but these are typical figures that are given. And then the moderate ones in green, and then the most severe form is in the central circle, the 0.5%. The 0.5% is a robust kind of figure. This is essentially those who end up under people like myself and usually end up in hospital. The larger figure, the 2 to 3%, a lot of these people would come to me as a psychiatrist. A lot of them will be managed by GPs in primary care then. And the wider circle is the one where some of these people may come into contact with general practice and some of them don't. But you in the ministry, look at people who might be actually be in the ministry, you in the ministry then encounter all these people, and they're the kind of people you can help. So it's not that you can't provide help for those in the other two circles, but they need medical help in a way that I don't think the outer circle does. Next slide, please. So I suppose I would see it like this. I don't think that there's one cause for depression. Now, it's an academic debate that's long-standing in the field about this, but I think that melancholy, severe depression is a separate entity. There may be some overlap. Certainly it can be difficult to differentiate with the much wider psychosomatic and neurotic type of depression. But that big circle, I think, is generated in a different way. The causes are different. That doesn't mean I think it's wrong to say they're ill, and it certainly doesn't mean it's wrong to say, it would be wrong to say they don't need help, because they certainly do, but I think they are fundamentally different. But that's really another topic beyond what we'd look at today. Next slide, please. So the worst form of depression, psychotic depression. Elizabeth Wurtzel obviously suffered from this. That's the thing I want to make clear about depression. It's got nothing to do with normal life. It's fundamentally different. So I'm giving you a lot of quotes to make the point. These are people, male and female, young and old, from hundreds of years ago, from today, all sorts of backgrounds, academics, GPs and so on, who've had this, who are trying to get across the message this is something fundamentally different. So this is the thing I want to make clear about depression. It's got nothing to do with normal life. In the course of life, there is sadness and pain and sorrow, all of which in the time and season are normal, as I was saying. They're unpleasant, but normal. Depression is altogether different, it's in an altogether different zone, because it involves a complete absence. An absence of affect, an absence of feeling, an absence of response, an absence of interest. But for all intents and purposes, the deeply depressed are just a walking, waking dead. Now, I think this applies to those two smaller circles, but it's important that it isn't really actually just sadness. I think absence captures it better. There's just no feeling. There's just this awareness that I ought to feel something as I'm talking to this person. As I engage here with my husband, I should have a reaction, but I don't. I'm completely devoid of feeling. And it's this profound emptiness, this absence of emotion that is so hard for people with depression. So that's why it's trying to capture this is somewhat different from sadness. It's not an extension of sadness. You kind of lose emotion altogether. Next slide, please. Okay, so just briefly then, because people like this, you have them in your church from time to time, they need people like me, they need secondary care, they need hospitals, they need treatment. So these are the people I might have to detain and bring into hospital, and have done so under the Mental Health Act. They need to be hospitalised, sometimes sectioned, that is brought in into the Mental Health Act, a section of the law, the Mental Health Act law. They need antidepressants. They may need other drugs, including antipsychotics, and they often have electroconvulsive therapy. ECT is still the best treatment that we have for depression. It is safer than antidepressants, and is a brilliant treatment for people who are severely ill with depression like this. It's become horribly politicized, and sadly can be difficult for people to get hold of sometimes, which is horrendous, given how effective it is. And we in psychiatry have a kind of ongoing battle against people who are trying to get ECT banned. We need ECT, it's life-saving, literally, for people with severe depression, where antidepressants don't work in a lot of these people. Okay, next slide, please. So, in the ministry, in our church, how do you help these people? So I was saying these are fundamentally seriously ill people. They need secondary care, they need hospitals. So go and visit them, okay? I know, it's easy for me to say, I'm used to going on psychiatry wards. I know they can be a bit spooky. But please do make the effort to go and visit. Human beings, like the rest of us, they're ill and they're suffering. So do think about them, pray about them, visit them. When you visit somebody with depression, when you're in contact, don't be afraid to ask about suicidal thinking, okay? It's very difficult, especially for Christian people, to confess that they're thinking that they wish they were dead, that indeed they're having thoughts about killing themselves, okay? Now, this is an expression, if you like, of how ill they are, how depressed they are. They're so out of it, it's so miserable that they want to be dead. Even as Christians, okay? And as Christians, they will feel particularly bad about thinking like this. So, but by asking, you're showing that you have an understanding of what they're going through. You're trying to understand how bad it is for them. You don't need to worry about giving some special answer. There isn't a special answer. But asking the question, showing by that and by a response that you're trying to understand how bad it is, and just making a comment like that, that must be horrendous. That must be horrible if you're feeling like that, okay? That is helpful, okay? There's nothing special like that. Just do that. And do ask them relatedly about, their walk with the Lord, their faith. Related to this, all sorts of horrific sense of guilt and self-blame for what they're going through. Somehow it's their fault. Somehow how they're dishonoring the Lord by being like this and so on. But they're ill. It's not their fault. They're ill. So, ask about these things. Ask about their guilt feelings. Try and encourage them, to pray, to sing praise. When you're profoundly depressed, you can't really do it, but you could try, and if you can, not like me, I can't sing, but if you can sing, sing something with them. read a hymn to them, something that will remind them of fundamental truths about our salvation in Christ, and encourage them, pray with them. And as soon as they're able, try and get them back out into church, to integrate them. They might only be able to stay for a little while. You might have to think carefully about that, where they might sit, be sensitive to that. They might need to kind of leave. They might not, they're going to struggle with this, especially when they're very ill. But do help them, try and engage them. As I said, we're psychosomatic, relational beings, and our depression affects us wholly. We don't want to be there, even though we want to serve the Lord. You've got that conflict. Encourage them to overcome that, to be there with the Lord's people. Support them in being there. Next slide, please. Then there's that wider group of moderate depressed people with more moderate depression who might end up in hospital, or they may not, but generally it wouldn't be appropriate for them to be in hospital. They can normally be effectively treated with standard antidepressants and perhaps with cognitive behavioral therapy or some other form of psychotherapy given by specialists. By specialists here, I don't mean people like myself or even psychologists, people who've got some training in this. And maybe based in primary care, maybe based in secondary care. But through a combination of a psychotherapy and antidepressants, this can be effective. Antidepressants are very effective drugs when you give them to the right people. Like all drugs, if you give them to the wrong people, they're not effective. And that's one of the problems when you get reports in the media about them not working. It's because, well, they don't work because you're giving them to the people who don't have depression. So, of course, they don't work. You know, what do you expect? It's like giving drugs that lower your blood pressure, antihypertensives, to people who haven't got high blood pressure. It's, they're not going to do anything. Well, they might do harm. Okay, so for moderate depression, next slide, please. So it's pretty much the same thing. Again, this is something that needs, beyond what we can provide ordinarily in churches, they need secondary care. They need specific treatments that are given by secondary, usually primary care. But they also need the same sort of support from, us in churches, to visit, to ask these questions, encourage them to come to church, encourage them to pray. It's difficult. They can't read the Bible because of the impact on concentration. Keep it short, keep it focused, remind them of fundamental truths, and do ask about these things, about their miserable thinking, their guilt, and their suicide. Next slide. And then there's this much larger group of milder depression who do not need antidepressants, but are very commonly given antidepressants and then they don't work. Okay, so there's much wider group. And there are various forms of other psychotherapies that may be used with some level of evidence for help. Next slide. So stepped care is an approach that's used generally, again, in medicine, where you try to titrate the level of your input to the needs of the person, the needs of the patient in front of you. So here, when we talk about mental illnesses generally, this is true form, we're focusing on depression here as an example of this, really. Because we're made in the image of God, we're made to be in relationships. Supportive relationships matter, and they're therapeutic. Okay, take a depressed person, stick them in a flat on their own. Of course, they're going to get more depressed. Okay, that's what we've got going on at the moment, sadly, with all the restrictions with coronavirus. So people need relationships, and of course, even with all that's going on in the legislation, I've got to be careful what I say. Then you're allowed to visit people for this kind of reason. You can visit people to help give care when they're struggling. It's important to remember that. If you know people who are struggling, you're allowed to visit them, and that's important to support them. Again, this isn't anything special. You don't need special training. You need to be a caring, compassionate human being who will go and support the person when they're struggling with their depression. Encourage them, because again, as image bearers, we're made to be active and doing things. So encourage them to try and do things. Think with them, what can they manage to do? What activities can they manage to do that will use their imageness in that way that we're made to express ourselves? So encourage them in relationships, encourage them in activity, useful work. Yes, you've got to eat properly, you've got to diet properly, you've got to sleep properly. These are fundamental things. You remember that when I ran through the features of depression. Disturbance of sleep is fundamental to depression. Disturbance of appetite is fundamental to depression. Disturbance of movement is fundamental to depression. So, you try and engage in those ways. So getting a proper sleep pattern established with so-called sleep hygiene. You can look that up. We're not going to deal with that in detail. But the principles are you can help somebody deal with these things. You do not need to be a medical or any kind of healthcare specialist to support people in this. And yes, alcohol and other substances do adversely affect mood and function. And yes, Christians do misuse these things, okay? So it can be sensitive, and it may be appropriate for a minister, an elder, be the one who explores this, but you should ask about abuse of these things, because you might be surprised, okay? Probably not, but if it's there, it's something that needs dealing with. And you need to handle it sensitively, but people do misuse substances even whilst they were confessing faith in Christ. Next slide, if it's the right one. Can you go back to? I think they got out of order. So this is just that thing about. So I've said I think there is, a severe melancholic type with the two smaller circles. It's distinct. These are illnesses that will affect anyone. You can't do anything about them. Just like you're going to get cancer, you can't do anything about it really. You can reduce your risks with all sorts of things, but fundamentally, you might get it. And it's not your fault then if you get it. You get, a heart attack or a stroke. It's not because, you did something wrong. You had it because it's an illness. It's the same with these. Psychosomatic illnesses, to some extent, they're more modifiable if you can modify your lifestyles, your patterns of behavior. But fundamentally, again, then there's something that happened to you. That's the external cause of stress, fundamentally for these illnesses. And we all have vulnerability. So the easy thing, I think it's easier if you see somebody who's severely depressed, I think, unless you're really prejudiced, you would recognize this person was sick. Okay? It's not so easy to recognize somebody is sick in this kind of psychosomatic, this neurotic category. I think they still are ill, they still need help. But these are the kind of people that are most easily dismissed. Okay. Now these are vulnerable people. They're vulnerable by the way they are, by the way you might be, the way the Lord has made you. Some of us are more robust mentally, physically, to the stresses and strains of life. And other people are weaker and more likely then to struggle with the stresses and strains of life. They're psychosomatically vulnerable people who get depressed, get anxious, and so on as a result of this stress that they're under. And for those of us who might be the stronger ones, who can carry on functioning very well when all sorts of things are going on in our lives, we might look at somebody and say, well, come on, when I was like that, when I had that loss, when I was made redundant, I didn't behave like that. And you kind of blame the person for failing to manage themselves, and it's really kind of their fault that they're struggling. But it isn't their fault. They're made like that. Some of us are made with much more emotional stability and strength than others. And we can bear the strain much better. And if we are like that, we thank God that we're like that. Because if you're not like that and you struggle under these things, that's a horrible thing. Because when these things happen, you become depressed and anxious and you struggle. And you need help. And you need the same kind of stepped care help that I was just talking about, all that input that I was talking about as well for the more severe forms of depression. You need that support to help you through that time. And it isn't your fault, because that's how the Lord made you. We all have our own personalities with our own strengths and weaknesses. And some of us have a proneness, a weakness, a vulnerability to these kinds of mental illnesses. Next slide, I think we jumped to. Next one, thanks. So I think this might be finally. Family support's crucial, okay? So on the one hand, of course, the depression has a negative effect on the family members. It's really hard work living with and looking after somebody with a depressive illness. So it has a big impact on husband, wife, children, the family close to the sick person. So remember that, you know, yes, we remember the sick person, we want to help him or her through this in the sorts of ways I've outlined, but also you do remember the family around who've got to bear the load and what might struggle with. It's draining for them, and so support from people in the church generally is helpful. You know, and in the book I've written about, you know, mature Christian men and women can provide this sort of help. Don't be scared off by the fact that it's a depression or a schizophrenia, some kind of mental illness. You can provide meaningful help. And it's a long job. Because these are long-term conditions, it's not kind of a couple of visits, you know, and that's it sort of thing. You know, it can be that if you're visiting somebody who's got the flu or coronavirus or something, you know, COVID, they get through it, a couple of visits helpful, that's it, job done. Not the case with depression, not the case with mental illnesses generally. It's a long-term job to help people through over an extended period. Long-term support for the patient, long-term support for the family.